Very good evening to all of you. I'm Arosha Disanaka, President of the Ceylon College of Physicians. And I warmly welcome all of you to this evening's session. It is a great honor and a pleasure for me to invite to have Dr. Anula Wijesundera, our very beloved past president of the CCP and also a past president of the Sri Lanka Medical Association, as the invited speaker for today. Now, delving a little into this program, this series of lectures. Now, the CCP is out on a mission to learn and become better from everybody. We are usually in the process, we are very strong in learning from overseas experts, but at times we tend to not pay so much attention to other learning sources, such as the wisdom and the experience of our very senior colleagues. There is so much to learn from their experience as their role models, and there's so much we can learn from them to make our careers progress equally well. So under that theme, we have this Pearls of Clinical Wisdom series. We've already had one such session with Professor Saman Gunatilaka, another past president. And this is our second session. We have Dr. Anula Wijesundera, who obviously will need no introduction, but Dr. Barana Millavithana, who is coordinating this program, will introduce her. On a very personal note, Dr. Wijesundera, I've known her, I've worked with her very closely from the time that I was a medical student. She was heading this organization called Jayagrahani, which was helping out people in the border villages. I don't know whether Madam is going to spend any time speaking about that program today. But when she was in that program, when she conducted medical clinics in some of those places, I used to join as somebody who, like a pseudo pharmacist, I used to join that program, trying to, dish out the medicine that had been prescribed. So I know Madam from the time that I was a medical student, and of course, Madam has been an encouraging source all along my career progress to the present day being president of the CCP as well. So she's a very special and a very dear lady to me, somebody whom I really look up to for guidance and advice, and who has been an exemplary physician leader, not just a physician, but a physician leader for this country. So thank you, Madam, for accepting our invitation to speak to us today. And then, of course, we brought forward the program by 1 hour to accommodate the SLCIM's program, which is going to happen later in the day. She very graciously agreed to that as well. So thank you for everything, Madam. So may I hand over to Dr. Barana Millavithana, who is coordinating the Pearls of Clinical Wisdom series, so that Barana can introduce Madam, and then Madam can speak to all of you. Thank you very much. Have a very pleasant evening. Thank you.
Thank you very much, Professor Arosha. And as a formality, I would like to introduce this program, Pearls of Wisdom. Today, we are going to have the second lecture in this series. And we are privileged to have Madam Anula Wijesundera, who is an eminent physician, and she's a senior physician in the country, who was the president of Ceylon College of Physicians, as well as the past president of Sri Lanka Medical Association. Today, Madam is going to enlighten us and inspire our new generation, sharing her experience in Polonnaruwa. So Madam is going to talk on the wonderful experience in Polonnaruwa. And thank you, Madam, and over to you.
Professor Arosha Disanaka, President of the Ceylon College of Physicians, fellows, members, Dr. Barana Millavithana, my former registrar at the Sri Jayapura General Hospital, colleagues, good evening, ladies and gentlemen. It is indeed a great privilege and a pleasure to speak to you, to be invited to address you today in the series, The Pearls of Clinical Wisdom. And I thank Professor Arosh for having given me this opportunity of addressing you today. It is indeed a great honor, and it was a great opportunity, Professor Arosh, when you asked to speak about the wonderful experience in Polonnaruwa. It was an opportunity for me to recall, recollect, remember, and reminisce the wonderful experience I had. And thank you for having given me this opportunity once again. The period I worked in Polonnaruwa, that was between 1986 to the period 1988, was in fact a period of tremendous strife in Polonnaruwa. It was a period of the last epidemic of malaria in Sri Lanka. At the same time, there was a worst epidemic of Japanese encephalitis. Hundreds of patients were admitted to the Polonnaruwa hospital with snake bite and deliberate self-harm, apart from which heightened LTT activities in that area and JVP atrocities and the movements of IPKF or the Indian peacekeeping force across the Polonnaruwa district were all problems that we had to encounter with. But I say it was a wonderful experience because the experience I gained from it by treating thousands of patients, and also the fact that we were able to overcome these problems, is indeed a cause for celebration. That is why I call it the wonderful experience in Polonnaruwa. My husband Ajita had already taken up the post of obstetrician in Polonnaruwa Hospital around about October 1985. And then in the annual transfer list, I applied for the post of physician in Polonnaruwa. But it said that it included the work of the pediatrician, there was no dermatologist, no psychiatrist. So I had to cover the work of all these specialties. As expected, I was the only applicant because Polonnaruwa was far from popular at the time, because it was the time of increased LTT activity in the Eastern Province. And Polonnaruwa was bordering on the Eastern Province. So I was not surprised to be the only applicant for that post. Of course, there was some time from the time of application to the time of taking up the appointment. So as I had to work as a pediatrician and a dermatologist, I made use of the time because I was a resident physician in the General Hospital Colombo at that time. So in my free time, I went to the Lady Ridgeway Hospital and I followed the rounds with Dr. Narada Varnasurya, now Professor Varnasurya, and brushed up my knowledge on pediatrics for about 3 months. And also I followed the dermatology clinics in the General Hospital. And at the end of the time, I was quite confident of managing the common pediatric problems and the dermatology problems. So I ventured at a time in Polonnaruwa because it was not popular at that time, because around May was the attack on Sri Mahabodhi with the death and the brutal massacre of about 125 pilgrims. And this was followed by the attack of Manampita Bridge. So it was not surprising that I was the only applicant. Anyway, so by the time I took up the appointment in January, I remember the date exactly. It was 11th of January. And at that time, there were widespread floods in the Polonnaruwa district. And I was driven there by my parents, Mr. and Mrs. A.D. Samaranaika, and my mother, Susila. And I remember my father wading through about 1 foot of flooded water as the Girithale tank had breached and the Girithale Polonnaruwa road was inundated with water. But we were safely taken to that by my father. And he insisted that I start work the next day, which was the 12th of January, rather than wait for the 13th, the Monday. So I was an obedient daughter and I took up appointment on Sunday. And then when I took up appointment, I found that there were only 2 Sri Lankan graduates and all other 6 graduates had been trained in Russia. They had learned in the Russian language and they did not know much medicine in English. And apart from that, their knowledge of tropical disease, as expected, was much to be desired. So as I started the work with them, almost every afternoon, I had to teach them the basics of tropical medicine, and also had to teach them the management of acute medical emergencies, especially snake bite, deliberate self-harm, organ phosphorus poisoning. So every afternoon, for a couple of months, this was a routine. I had to teach them. And similarly, the obstetrician and the gynecologist and the surgeon also taught these doctors the basics of tropical medicine and related obstetrics and gynecology. So, but I'm happy to say that at the end of the appointment, with the wealth of teaching and also the wonderful experience they had, they became very competent house officers and were able to manage very well all the problems they encountered. And in fact, they were experts at doing lumbar puncture when the Japanese encephalitis epidemic arose. I will now draw attention to the period 1986 to 88, which was the last epidemic of malaria in Sri Lanka. During that time, there were approximately 700,000 cases of malaria in Sri Lanka. And malaria was the leading cause of admissions to all government hospitals in Sri Lanka. And to the Polonnaruwa-based hospital, 35% of all admissions to the medical and the pediatric wards were cases of malaria. And malaria took a tremendous toll on the farmers. Apart from being debilitated with the high fever and the recurrent attacks of malaria, the fact that they're working paddy fields, the farmers working in the hot, humid weather, they were often dehydrated. And often in coming to hospital, some of them had to walk a certain distance to reach the public transport. And by the time they reached Polonnaruwa Hospital, many of them, they're dehydrated and exhausted. Apart from the illness itself as a result of traveling. So many of them, patients had to be rehydrated and resuscitated before they were actually treated for malaria. And in fact, many of the patients, when they came to hospital, they preferred to wait in the sun. We called it, they preferred to awatapinna. And they came saying that the unagedia was palpable, which was the palpable spleen. So they knew that. And they too diagnosed malaria before they actually came to hospital. And in fact, malaria, recurrent attacks of malaria, not only made them anemic, debilitated, they were also, they were dehydrated, they were exhausted physically, mentally, and emotionally. And as well, economically, malaria deprived them. And in fact, in the words of the farmer, very often they used to say, malaria apiva nomara maranava, that malaria actually destroys them without actually killing them. Another group of, another age group that people affected, that was affected by malaria were the preschool children. And here again, recurrent attacks of malaria led to anemia, growth retardation, stunting of growth, and hepatosplenomegaly. And it was often found that when children were admitted with malaria, whether it was malaria itself or whether it was an incidental problem like pneumonia or a diarrhea disease, the palpable spleen and hepatosplenomegaly was invariable finding, indicating that there was a very high incidence of malaria within this area. And this led me to find out the splenic survey, to do a splenic survey among the school children in this area. And I selected 3 areas, the town areas of Polonnaruwa and Higuragoda, and then the middle of the Polonnaruwa district, that is Aralaganvilla and Manampitiya, and the distant part of Polonnaruwa bordering the Batiklo area like Elleveva and Pimburatheva. And I did splenic surveys, the results of which I will convey to you, which showed a very high incidence of palpable spleen or splenic rate in the areas of the Polonnaruwa bordering the Batiklo district. Can I have the slideshow now? So this is what you see is the Polonnaruwa Hospital. This was initially built during the time when the Right Honorable Mr. D.S. Sennaik was the Minister of Agriculture. And before the first batch of colonies were settled in Polonnaruwa, he made sure that there were adequate health facilities for the patients. And he was instrumental in getting the Polonnaruwa Hospital, and that was built around 1936 after the first major epidemic of malaria ravaged Sri Lanka in 1935. This hospital was elevated from a district to a base hospital in 1940. And the time that I worked in this hospital in 1986, there were only 3 consultants. My husband was the obstetrician, Dr. Gamini Gundilka was the surgeon, and I was a physician and pediatrician. And this is indeed a far cry from the Polonnaruwa Hospital, which was greatly developed during the time when our former president, Mr. Maithripala Sirisena, was president, and previous to that when he was Minister of Health. So this is the Polonnaruwa District General Hospital now. There are over 35 consultants and 7 operating theaters, and even cardiac angioplasty is being done in Polonnaruwa. And these are the ladies who were admitted with malaria. You can see they look extremely ill and debilitated. They are all covered. They are shivering with fever. And these account for 35% of all admissions among the pediatric and medical wards during that epidemic of malaria in the Polonnaruwa district. I thought I'll briefly go through with you the history of malaria in Sri Lanka, or the 100-year history of the mosquito bite. It goes on from 1911, when the first field center for malaria was built in Kurunegala, until the time of 2011, when the last indigenous case of malaria was found in Sri Lanka, in a Sri Lankan Ranaviru in a Mulathivu camp. So, of the bite. And in between was the worst epidemic of malaria, which occurred in 1935, where more than 80% of our population, or nearly 5 million, were affected with malaria, and more than 80,000 deaths occurred as a result of malaria. Subsequently, with the introduction of DDT and all other preventative measures, the incidence of malaria came down in the 1960s, and fortunately, with the introduction of DDT. But subsequently, with the development of resistance, and because continuous vigilance was not maintained, malaria re-emerged in the 70s. And then you see the second epidemic of malaria, where there were about 600,000 cases. And then the final major epidemic of malaria was in 1986, the time I worked in Polonnaruwa. And subsequent to that, with the decentralization of anti-malaria campaign and more responsibility being given to the district level and more money being spent on malaria, reduction of mobile clinics, active case management, passive case management, and also with the money from the World Bank project, the Rollback Malaria Initiative, and also the money given for AIDS, TB, and HIV control, and the introduction of artemisinin, malaria was controlled in Sri Lanka. And after the final indigenous cases, last indigenous cases was detected in 2011. 3 years later, Sri Lanka was certified malaria-free by the World Health Organization, and that occurred in 2016. And I will show the consequences of malaria in the Polonnaruwa hospital. Now, this is an infant, and you can see this child with hepatosplenomegaly, and that is a result of recurrent attacks of malaria. Although it is believed that malaria is rare in the first year of life and in infancy, malaria was often seen even in the first 3 months of life and in the first year. It is often believed that malaria is rare because of passive transfer of immunity from the mother to the baby via the breast milk and the placenta. And also the deficiency of para-aminobenzoic acid in a purely milk diet. But in spite of these protective phenomena, malaria was seen because of the high incidence of malaria. These little infants also got affected. And this was a case of congenital malaria. You can see this is an emaciated baby, was born preterm, had a low birth weight, is grossly anemic, and had hepatosplenomegaly. And that was a blood picture obtained by heel puncture at the time of delivery. And that confirmed malaria. And doses of anti-malaria treatment and further management was done. And I'm happy to say that we were able to bring him back. And this shows malaria in the preschool group. Here again, you can see hepatosplenomegaly as a result of recurrent attacks of malaria. And these are two brothers from a place called Polonnaruwa in the border of the Polonnaruwa and Batiklo. These children are aged brothers from Polonnaruwa, 6 and 5. But you can see how emaciated these children are, anemic, undernourished, pot-bellied, with hepatosplenomegaly as a result of recurrent attacks of malaria. I mentioned to you that the presence of splenomegaly motivated me to do the spleen rate in the schools in that area. And we did a spleen survey in Royal College Polonnaruwa. The spleen rate was found to be 10%, indicating and also Hinguragudi areas to be hypoendemic area of transmission. Whereas the middle, the areas in the middle of the Polonnaruwa district, like Aralaganvilla, where the spleen rate among school children examined was 30%, indicating that to be a mesoendemic area of transmission. of bordering, Polonnaruwa bordering on the Batticaloa district, the spleen was palpable in more than 50% of children whom we examined. And this showed clearly that it was a hyperendemic area of malaria transmission. From Anula, you can see he too is growth retarded, has a gross hepatosplenomegaly. He had a 10 centimeter liver and almost a 20 centimeter spleen. He had pancytopenia. The high malaria antibody titer was confirmed by sending the blood to the Department of Parasitology. And this was done by Professor Carmini Mendis. And I performed the liver biopsy on this child. And this was sent and was transported to the Medical Research Institute. And this confirmed tropical splenomegaly syndrome, because there was hepatic sinusoid lymphocytosis, Kupffer cell hyperplasia, and lymphocytic infiltration, confirming the diagnosis of tropical splenomegaly. This child, the parents refused surgery, so we managed him with blood transfusions and prolonged anti-malarial treatment. And this was another serious complication of malaria. This was a young lad who was anemic, jaundiced, and you can see the pitch black urine as a result of intravascular hemolysis and hemoglobinuria. And this was a lad who had G6PD deficiency precipitated by pneumococcus therapy. And we also appreciate that this problem can occur as a result of quinine therapy and also as a delayed hypersensitivity reaction as repeated attacks of Plasmodium falciparum malaria. And this was an interesting admission to the medical ward. This young lad was admitted, was admitted with abdominal pain, right? But when he was admitted, he was very pale. He was almost in a state of shock. Examined the abdomen, relieved tenderness, rigidity, and guarding, an acute abdomen. And I knew that this was a case of an acute abdomen. And it was a Saturday morning, but fortunately, the surgeon was available and he was operated on. An emergent laparotomy was done, and this was found at laparotomy, a ruptured spleen. So this was a farmer who had minimum trauma, and as a result of recurrent attacks of malaria, he had an enlarged spleen, and with minimal trauma, this was a consequence. And fortunately, he survived due to the early diagnosis and the presence of the surgeon over the weekend. So these are the consequences of malaria in the 100 years. There are over 5 million cases of malaria, over 400,000 cases in 1970. And 1987, there were 600,000 cases, and the leading cause of admission to the government hospital at the time I worked there. As I told you, there's been an important cause of mortality. In 1935, there were 80,000 deaths. But fortunately, from 2010 onwards, there have been no deaths from malaria. In children, recurrent attacks of malaria lead to chronic ill health, growth retardation, and poor mental development. And agricultural communities, malaria, asthenia, loss of productivity, economic loss. And malaria in pregnancy leads to abortions, preterm deliveries, anemia, and acute pulmonary edema at the time of delivery. And malaria in the fetus results in low birth weight, anemia, congenital anomalies, and also consequences of congenital malaria. I just thought I'd recapitulate the consequences of malaria and the importance of having eliminated this drastic disease from Sri Lanka. I will now briefly deal with some of the new things I discovered during this epidemic of malaria. The neurological complication of malaria. And this I presented at the 100th anniversary of the Sri Lanka Medical Association at the 100th centenary celebrations. And I'm happy to say that this paper received the best prize, which was the Wijesundera Award for the best prize at the centenary celebrations. I explained the neurological complication of malaria in the Polonnaruwa District Hospital, and these were febrile fits, the acute cerebellar syndrome, toxic confusional state, cerebral malaria. The Guillain-Barre Syndrome, I described in 2 patients. It was the first mention of Guillain-Barre Syndrome in Plasmodium falciparum malaria, and also the first mention of the acute syndrome complicating falciparum malaria. I also described the extraepidemial tremor, a delayed psychosis, and myopathy. And I mentioned the acute cerebellar syndrome because farmers who came said that they were, as a result of the malaria, they were unable to walk on the near area of the farm, of the field. And that was an indication that they had cerebellar ataxia. And this was at the height of fever. And I describe this as an acute cerebellar syndrome. At the height of the fever, falciparum malaria, the hyperviscosity, the cytoadherence of parasitoid cells with each other, and the hyperviscosity and the parasitemia involving the cerebellum. And this caused the cerebellar syndrome. At the time, Professor Janaka described the delayed cerebellar syndrome, and which he described as immunological complication of Falciparum malaria. And there were two descriptions of the and the acute cerebellar syndrome in the British Journal of Tropical Medicine. So it was so with the incidence of malaria waning off at this time, came Japanese encephalitis came to the fore, and at this time it was extremely it was a common sight to see children with height of fever, confused, admitted with fits, or sometimes in various stages of coma, delirium, being admitted to the ward. But at this time, as I said, our doctors who were initially trained in Russia became very competent in managing, and they were very competent at doing lumbar punctures on these patients with Japanese encephalitis. So we managed these patients conservatively. They were managed for general management of unconscious patients. All of them had blood film examination to exclude a possible incidental diagnosis of malaria. Lumbar puncture was done, but we had to exclude incidental meningitis or cerebral malaria. And we found that during this phase, by our own experience, we defined three clear phases of Japanese encephalitis: the prodromal phase, the acute encephalitic phase, and the post and the convalescent phase. And apart from the management of encephalitis, they were given anticonvulsants, the management, antibiotics were indicated, and for patients who had a prolonged encephalitic phase, it was found that mannitol was very effective during the acute encephalitic phase when they had cerebral edema. And this was used and by a piece of trial and error. And I must say that we never used steroids during this time. And there was communication between the pediatrician and patients of Anuradhapura, Polonnaruwa, who treated these patients. And through consensus, we decided on the, because it was a case of learning from each other and from our patients. And this time, between the period of 1986 to 87, this was a remarkable experience of learning for me. And what are things I did not know as a medical student or as a physician, which I had never read. I learned from my own patients and from the discussions I had with my colleagues. And at this time, I started to record all the interesting cases I saw. I observed, I recorded, I photographed, and I came to conclusions. There were no computers or IT, there was no Wi-Fi. So I maintained all this information in ordinary exercise books. So I had a curious mind, and I collected all this. Some things were new. But these were all experience that I learned from my patients. And about once in 2 months, when I went to Colombo, I made a beeline to go to the Sri Lanka Medical Library. And the two books I really read were the Mansel's Tropical Atlas of Malaria, and also Adams and Magriffith's Tropical Clinical Disease. And reading these books, I gained a wealth of experience. And I photocopied all the chapters on malaria. And of course, there was very little information on encephalitis in these books. And so I was able, some of this information I found, but there was new information I gathered. And it was based on these clinical observations and the subsequent findings that I was awarded 2 orations on the work I did in Polonnaruwa. The first was the the SC Paul oration, which I was awarded for the presentation, Malaria, the Scourge of Polonnaruwa in 1988. And I'm happy to say that I was the first woman selected to deliver the SC Paul oration, the oldest of medical orations in Sri Lanka. And 2 years later, I was awarded the same oration, the SC Paul oration, for the work I did, for the clinical work and the research I did on Japanese encephalitis. And this oration was titled Japanese Encephalitis, the Plague of the East. And also, as I told you, the work was also published in the Ceylon Medical Journal, the Tropical Doctor, the Postgraduate Journal of Medicine, and also the British Journal of Tropical Disease and Infection. Moving on from malaria, I must then bring your attention to another epidemic that occurred in Polonnaruwa, and that was the epidemic of Shigella flexneri in the Polonnaruwa district. It first happened in Matale, and then because of contamination of water, of the river water, it spread to the Polonnaruwa district. And Shigella flexneri was a major problem during that period. And an ambulance driver who transported some very ill patients from Matale to the Congenital Hospital. On his return journey, this stupid man stopped the ambulance by a river, a tributary of Abangaga, and he washed all the soiled carpets and the seats with this contaminated water and contaminated the water of the Abangaga. And you will know that Abangaga is a tributary of, was actually part of the Parakrama Samudra. There was Abangaga, the Thopa Veva, the Dimutulu Oya, and the Erebudu Oya, which King Parakrama Bahu the Great joined together to form the Parakrama Samudra. And with the infection and the contamination of the water of the Abangaga, the entire Polonnaruwa, the water of the Samudra were contaminated. And there was a severe epidemic of Shigella flexneri in Polonnaruwa. And unfortunately, the patients who developed did not respond to the standard management of bacillus dysentery, because this strain of Shigella flexneri was resistant to nalidic acid and furazolidone. It was only resistant to, it was only sensitive to mesalinam, and there was no mesalinam in the Polonnaruwa district. And at that time, I rang up the Director General of Health Services, Dr. Joe Fernando, and he immediately obliged, and he sent 2,000 tablets of mesalinam by train, and I was able to collect the drugs from the Kadurula railway station the next day. And this fortunate helped me to control the severe epidemic of Shigella flexneri. And there I must say that when you're prepared to work, to go out in the periphery and work, even all the directors of the Department of Health, they are there to help you because they appreciate the work done and the interest shown. And I'm very grateful to Dr. Joe Fernando, who was the Director General of Health Services, for having provided me the drugs within 24 hours. And that helped me to control this epidemic. And I was able to present the findings of the Shigella flexneri epidemic in the Asian Journal of Infectious Disease, which was held in Sri Lanka in 1987. I will now move on to a snake bite. In fact, the time I went to work in Polonnaruwa, there was antivenom serum was not used. And it was the normal pattern of people who were bitten by snakes to seek treatment from the Sarpaveda. And in fact, the first patient who was the first victim of snake bite was admitted to Polonnaruwa Hospital. When I assumed duties, was actually did not die of the snake bite, but he died of a consequence of the treatment received from the Sarpaveda. This Sarpaveda used nasal treatment. And you introduce some oil to the nose and the ears. And in fact, this unfortunate guy developed severe chemical pneumonia, a lipid pneumonia, and we had to suck secretions continuous. And he developed respiratory failure. And in spite of the antibiotics, the steroids, and the ventilation, he was too ill. And unfortunately, he succumbed. Not as a result of the snake bite, but due to the Sarpaveda treatment. In fact, the second patient with with the snake bite who was admitted, the house officer was about to give this patient antivenom serum, which I introduced to Polonnaruwa. But unfortunately, a monk, Buddhist monk, came and immediately tried to take this patient away, again to take to the Sarpaveda. And all the pleading that the house officer did at the time was of no avail. Fortunately, at that time, my mother, who happened to be come in search of me, she had just come to Polonnaruwa, and because I was getting late to come home, she came and she saw the commotion, and she told the priest that her daughter was in fact the physician, and that there was a novel new treatment for Polonnaruwa, and that she assured the priest that this victim could be saved. Only because my mother was a senior lady and he had some respect for the lady, so the priest agreed. And we gave this patient antivenom serum, and the patient survived. And in fact, that message which the priest, and in fact, because of that persuasion and the fact that we were able to keep the patient in the hospital and give the antivenom, had a tremendous impact. And in fact, it was a priest who did the rest of the health education, and he went in all his sermons. I implored on him to talk about the value of antivenom serum and to bring patients who were victims of snake bite to the Polonnaruwa hospital, and that we had the facilities to save these patients. And in fact, the message worked. And from the 1988 onwards, from 1986 onwards, the number of patients who came with snake bite invasion improved. And with every successful patient who was treated, we sent the message and health education was done. And more patients came to the Polonnaruwa hospital as a result of snake bite invasion. And we were able to help these patients and save valuable lives of farmers. In fact, snake bite envenomation snakes were found everywhere in the Polonnaruwa district, right? They were found sometimes in footpath, when patients working in paddy fields, sometimes walking in footpaths or walking in paddy fields. Snakes were everywhere, and in fact, there were snakes. I encountered snakes even in our porch, right? In our porch, and also there were snakes even inside the theatre of Polonnaruwa Hospital. There was a viper in Polonnaruwa Hospital, and even crates in our porch at Polonnaruwa. And in fact, there was a belief that the word Polonnaruwa was coined from Guillain-Barre. That was one of the words, one of the myths of the name of the house Polonnaruwa was named. So snakes were everywhere in Polonnaruwa district. And in fact, there were cobra, and in fact, cobras, snakes were, as I told you, there were frogs. There were frogs, and these frogs came in search of, and there were even in the outlets of, there were cobras, as I told you, everywhere. Sometimes they were in, and these cobras came in search, sometimes they came in search of frogs in the toilets. And so we had to make sure that toilet outlets were covered with fine mesh to prevent the snakes from coming in through the to the toilet outlets. And all the toilet outlets were covered with fine mesh to prevent the snakes from entering, right? So believe it or not, there was even a cobra in the operating theater, and my husband was and the surgeon were always in the habit of turning the boots to see whether there were any snakes before they actually wore the boots, because a cobra was actually found inside the theater and was killed by the surgeon in Polonnaruwa, by the anesthetiist in Polonnaruwa, Dr. Kamalanesan. So these are really true facts. So that is why we were always aware of the danger of being bitten by snake bite. So actually, so whenever I'd answered a night call in Polonnaruwa, and sometimes when I took took a footpath rather than walking on the main road, I often carried a torch and I wore covered shoes and I walked stamping my feet so to keep the snakes away, flashing the light and walking, stamping my feet, because snakes are very sensitive to sound, to vibration more than sound. And that was one of the precautions I took to make sure that I was not bitten by a snake when I answered the night call during the time I worked in Polonnaruwa. Another problem in Polonnaruwa was the incidence of so another problem in Polonnaruwa is, of course, deliberate self-harm. Of course, at that time, during the period of 1995, we had the highest rate of self-harm in Sri Lanka, and where the incidence was 42 per 100,000 deaths from deliberate self-harm. And there were approximately 25 deaths per day, and sometimes, for the most frivolous of reasons, pesticides were swallowed, and this was due to the widespread availability of pesticides, and for some, therefore, the most frivolous of reasons was which was the death of a pet or mother scolding. There was a habit of taking these pesticides because of the wide availability of agrochemicals in the Polonnaruwa district. So that it was a very common task of the very common cause for the most frivolous of reasons. Farmers, whether it be just the minimum of provocation, because the availability of organophosphorus, the farmers and even school children were in the habit of taking these insecticides. And in fact, it was that Sri Lanka had the highest incidence of deliberate self-harm. And during that time, in the mid-90s, the president of that time, Mrs. Chandrika Bandaranaike Kumaratunga, introduced a presidential task force to treat this problem. And it was during that time that the most potent of the organophosphorus, the 3,4-DEP monocotophos, diaminophos, were excluded because these were very toxic and freely available. And as a result of banning of these pesticides, the incidence of deliberate self-harm fortunately came down. And I think at current, we were the highest in 1995, the global highest rate of deliberate self-harm from pesticides. But now I think we are about the 14th, and that is due to the withdrawal of the organophosphorus things. And at Polonnaruwa, it was a very common sight on a casualty day to find young men for the most frivolous of reasons. It may have been just an accident, just an argument with over a land dispute, or mother, school child, for the most frivolous of reasons, because of the availability of organophosphorus and the availability for the most frivolous of reasons, children and even adults took this. And unfortunately, as this sort of banning of the most potent pesticides, we have been able to control this thing to a certain extent. I must now, so that was about snake bite and about deliberate self-harm. Then I must talk about the monkeys of Polonnaruwa. And they were the monkeys of Polonnaruwa, they were everywhere. The monkeys were everywhere. They were in the archaeological sites. They were in our gardens. And they were even on the rooftops. And I must say that at one time they destroyed the rooftop of Polonnaruwa. And over a weekend, there was no possibility of working in Polonnaruwa, so the anesthetist and the surgeon took leave that weekend. And so the director instructed the roof of Polonnaruwa hospital to be repaired because it was totally damaged as a result of monkeys destroying the roof. So during this weekend, it was very unfortunate that a woman was admitted having ruptured ectopic pregnancy. And my husband was obstetrician at that time, knew that if she did not operate, this woman had to be transferred to Matale. And that meant that this woman could not sustain, that it was about 30 miles back to Habarana, and then from Habarana to Matale. So he knew he had to take a drastic step. And he decided to operate on her, but there was no theater. So he decided to operate on her in the labor room. There was no anesthetist because anesthesists were both away. So but the theater assistant was there. And so he operated on this lady in the labor room. It was the anesthetic assistant who gave the oxygen, the nitrous oxide, and the halothane. And my husband was able to save this woman who had sustained ectopic pregnancy. If he transferred the patient to Matale, undoubtedly that patient would have died. So this was a heroic thing that was done. And we had to adopt certain things, and they were very successful. And this woman was so grateful that in the end, that child, she showed her gratitude to my husband by giving him 2 eggs and a packet of lemon puff biscuits. And my husband was so emotional. He told this lady, "You take it. You need it more than me." But she insisted that my husband took it. And that was the level of gratitude of these poor patients from Polonnaruwa. So I thought I would just say this, because you have to improvise things working in these remote and distant hospitals. And it was done. And this woman's life was saved, because if my husband did not operate on her, she had to travel 60 miles, first to Habarana and then to Matale. And it's very likely that this one would have died, because at the time of surgery, there was so much of blood in the peritoneal cavity, and the emergency surgery done in the labor room, in the remote and distant hospitals with minimum of facilities, the theater with a assistant and the nursing staff saved the life of this mother. So I thought I must share this anecdote and tell that when we work in remote and distant hospitals, you have to take innovative steps and sometimes take decisions, but these are often done in the best interest of the patient. And here I must also add about the surgeon who was there at that time, Dr. Gamini. This was height of LTT activity during the Polonnaruwa district, and he too worked with great commitment, and he too operated 24/7, as my husband did, who was an obstetrician at the time. And sometimes the anesthetist was extremely competent, worked Monday to Sunday, but on Monday to Saturday. But sometimes when he worked on leave, my husband and even the surgeon learned to give their own anesthesia. And by this, they were able to save valuable lives when they considered that patients were too ill to be transferred to Matale, which was nearly 60 miles away from Habarana to Matale. So that was the level of commitment that the surgeon and also obstetrician showed at that time. So I thought I must share this experience with you, that they worked 24/7. And even when the anesthesia was not available, sometimes if they considered that a patient was too sick to be transferred, they worked giving their own anesthesia. And of course, they helped each other. And they too learned, they went through and also got trained in anesthesia just as much as I, before I took up the appointment in Polonnaruwa, when I knew I had to work as pediatric and physician, I too went to the Lady Hospital and also worked at the skin clinic. So to update my knowledge on these diseases, because I had to work as a pediatrician, dermatologist, and psychiatrist too, when I worked during the period I worked in Polonnaruwa. And I must admit that that I was a pregnant mom during the severe epidemic of malaria and Japanese encephalitis. And in fact, I was delivered by my husband. It was a footling breach, but my husband was convinced that I had a cephalic presentation. But we had to, about 1 week before the delivery, we had to go attend a seminar, the malaria conference in Anuradhapura, and it was starting at 8 o'clock. So we we left early, and on our way to Anuradhapura, there was a tremendous hump on the road near the Air Force checkpoint, and my husband didn't actually see it, and there was a tremendous jolt I got a tremendous jolt, and I think at that time the baby must have turned inside. So the cephalic presentation suddenly became a breach, and at the time of delivery, my husband was amazed that it was actually not cephalic but breech. But however, so anyway, I was about 1 month preterm, and so he developed a footling breech. And at that time, there was no surgeon because it was a Sunday afternoon. But my husband was confident that the surgeon who went on Saturday often returned on Sunday. He boarded the bus at 12 noon in Colombo at 6 p.m. And he knew that the bus would arrive in Polonnaruwa at 12 midnight. And true to form, at 12 midnight, Dr. Kamlesh anesthetist arrived. Fortunately, of course, it was a breech delivery. It was a sister breech delivery. And because the baby was small, the footling breech was delivered without a problem and did not need any anesthesia. So I thought I'll share this experience to you of how my daughter was delivered by the father, again in a very and a footling breech in a remote and distant hospital. Of course, anesthesia was not there, was almost there, but it was a normal breech delivered vaginally. So I thought I'll share these experiences to you, so the things are done, and you have to take these decisions when you work in remote and distant hospitals in Sri Lanka. And I thought it'll give, and also the surgeon and the obstetrician and all of us work together. And in fact, during the time of the LTT terrorism, all this, the Aranavir who injured in battle, they were admitted to Polonnaruwa Hospital as a result when they were subject to either landmines, bomb blast, and or these various injuries as a result of the war. And Polonnaruwa Hospital was the center and center for receiving Ranavir injured in action. And they either came by ambulance, and when the siren went, or when we heard the helicopter landing at the Thopa school grounds, all the staff in the Polonnaruwa Hospital, whether they were duty or not, rushed. And Surgeon Dr. Govindra Gunthekar was there to carry out the triage, and we all helped him. And he worked 24/7, and everyone helped. And there was a tremendous cooperation from all sectors of staff, from minor staff, everyone. And the surgeon did tremendous work during the LTT terrorism and subsequent during the JVP atrocities, during the time we worked in Polonnaruwa. And I must say that, and I must add that my daughter, who was actually, if I were to boast, a little boast actually, although she was a footling breech, she entered the medical faculty, and I must say that she got, and if I was allowed to watch, she obtained first class and distinction in all 5 subjects, and is now training in I. And as a coincidence, I must mention that her future husband, our son-in-law, Navoda, was also delivered by my husband in Polonnaruwa, because his father was a chief inspector at the Himgraboda hospital. And it was during that time that my husband had to do a C-section. But unfortunately, at the time, there was JVP atrocities, and there were frequent power cuts. And my husband insisted that there was a generator, and he provided the generator when the C-section was done on my son-in-law. So those, I thought, were interesting anecdotes, which I thought I must mention to make this talk interesting. And the fact that when you work in distant and remote areas, you go that extra mile to do your best for the children, to do your best for the patients. Yeah, and you often you face certain risks, but always fortune favors the brave. And even the surgeon who worked with minimal resources, he worked from head to toe, doing surgery. Even boreholes was done by him, including laparotomies. And my husband was there at the time when the surgeon was leave, performed laparotomy on bomb blast victim, on a patient, on a victim, and he was able to do minimum surgery and to try that period until the surgeon was available. So when you work in minimum resource setups, you make heroic decisions, and fortunately, fortune favors the brave, and you come out with flying colors, and often with successful results. and you can applaud the decisions made, the courage taken, and the wonderful results obtained. So, and I must add, I think coming on close time, we formed the clinical society at that time, the Clinical Society of Polonnaruwa at that time, and we invited doctors from Hinguragoda, Minneria, Bakamoon hospitals, and we had clinical meetings, and we had fellowship for all the doctors and the medical, the interns and the AMPs and the bodies, and they all enjoyed the fellowship which we at the end of the time. So, so that was the clinical society. And I'm happy to say 35 years hence this year, Gamini, Ajit, and I were invited as the chief guest and the guests of honor to the Polonnaruwa Clinical Society annual sessions. They celebrated 35 years of the Polonnaruwa Clinical Society. And we were very, very happy to attend this during this time, because it was the Polonnaruwa Clinical Society was in fact founded by us during the time we worked in Polonnaruwa during the period of LTT, strife, JVP terrorism, malaria, Japanese encephalitis, snake bite, and deliberate self-harm. So I think I would like to conclude this. I would like to, and having spoken about snake bite, I would like to show one of the victims of snake bite, and actually this was a stuffed polanga, a tit polanga. Actually, this was given to me by the grateful patient who had some knowledge on taxonomy. This tit polanga, he removed the flesh and stuffed the tit polanga with cotton wool, and this was given to me as a gift for saving the life of this patient who was bitten by. He had tremendous neurological complications and some renal complications, but he survived because of the availability of antivenom toxin, and also we were able to give it to him because by this time the message for the antivenom serum was all over the Polonnaruwa district, and he came early and came. And these are children, my children who are in Polonnaruwa. This was, I think, the New Year time, and they are in their cloth and jacket, and my son is wearing a sarong, and they are playing with this stuffed tit polanga, right? And so this survived for about 2 years, but finally this tit polanga, we had him near the fan light, and this tit polanga was shown to all the visitors who came. And by the time we ended our period in Polonnaruwa, about 3 years, the snake also degenerated around that time. But I thought I'd share this with you. And so I would like to conclude this. I would like to take this take-home for the doctors, because I want to stress the importance of malaria, and in order to always be aware of the diagnosis of malaria, especially people who have traveled, who present with fever, and also Sri Lankans who have traveled to malarial areas, because who have traveled to malaria endemic areas in the past 6 months, always obtain, whenever you encounter a patient with fever, where there's a travel history, you must always obtain a travel history. Otherwise, you will not be able to diagnose malaria. So always obtain travel history in a patient who presents with fever. And remember, and this will help to think of the diagnosis of malaria and diagnose it early. So if ever you have a patient with malaria, with fever, always get a travel history so that you will not miss a diagnosis of malaria. Thank you. And often I will express my gratitude to the patient who have survived in Polonnaruwa, despite who have been plagued by malaria. Many of them have died of encephalitis by polangas, and some have been attacked by the elephants. They have suffered from the atrocities of LTT terrorism, and some have suffered the effects of JVP terrorism. But they have not abandoned the Polonnaruwa district. True to their belief that agriculture is the lifeblood of our economy, the people of Polonnaruwa have not abandoned Polonnaruwa. They have survived. True to the belief that agriculture, lifeblood of our economy, they have survived. And Polonnaruwa, fortunately, is now safe. And I will leave you this beautiful sunset over the Polonnaruwa, over the Parakram in Samudra. And I thought I'll leave you with this beautiful scene of Parakrama Samudra, built by Parakram Bahu the Great. Thank you for your attention.
Thank you very much, madam. It is a wonderful experience, actually. It's inspirational, and you have mentioned your commitment as well as you shared your clinical expertise with us, which actually these things not seen these days, as well as what are the challenges you face. And most of us, the young physicians, we are working in the peripheries, and how you overcome in the resource poor setting. So thank you very much for sharing your experience. And I would like to ask anybody, is there a question or any comments? Can unmute, and madam will unmute and ask the question, and madam will answer it. Because there's no questions in the chat box, because if anybody's won't, either raise your hand or can unmute. There's a yeah, it's just a comment. Thank you very much for the inspirational talk. It's not a question. And if there aren't any questions, actually, I would like to conclude the session. First of all, I would like, on behalf of the President and the Council of the Ceylon College of Physicians, we are grateful, madam. With the short notice, you have accepted this invitation, and you have delivered the lecture which inspire our young generation. And first, so madam, thank you very much for your the talk. And next, I would like to thank the council as well as the office staff of Ceylon College of Physicians and our IT team for arranging this webinar. And finally, this webinar will be uploaded to the YouTube channel of Ceylon College of Physicians. Those who missed this talk can stream the lecture and go through it. And thank you very much, and good night to all of you. Thank you.